I think we take the pride that we will be the first one to detect these malignancies. Patient comes with atypical symptoms to the outpatient, and probably an endoscopy is very, very highly sensitive. Yeah, thank you. And very specific in picking up, and our diagnostic sensitivity of picking up gastric malignancy on endoscopy, even though we apply techniques like NBI technique or even the staining techniques, I think our pickup rate is very, very high. Maybe the endoscopy rate is very high. So I'll slightly modify the talk what my previous speaker did, a fantastic job of elucidating all the complications possible in the post-gastrectomy state. Now, how common they are? This is something which actually wonders. When we have very good surgeons who have a planned surgery, probably the burden is not so much. Somehow you are able to manage them very nicely. Are they preventable? I think this is something which makes, we heard lot of techniques and the last picture shown by my learned speaker before shows that there are a lot of techniques to prevent all those complications which are expected. How to recognize? This is what happens. A patient who gets a total gastrectomy done or a subtotal gastrectomy done comes with a lot of complications. We divide them, is it related to the surgical procedure or is it purely medical which is continuing? The nutritional issues probably make a very, very, very important in the total outcome. That means has psychological anorexia and true anorexia and nutritional supplementation, and also he is given a guarded nutrition. So I think all these do matter. And the time to recover. So I think this is something which when I send a case to surgeon and it takes about 15 to 20 days for the entire procedure to be completed, and when he comes back, his main problem is the nutritional recovery and the post follow-up and the cost implications following the surgery. When we try to give him a nutritional therapy or a supportive therapy, may not really click at that time. And sepsis seems to be one of our problem. What happens is, these people, as somebody nicely put, I think Sendil and all others put it, that the tumor biology is on one side and the host immunity on the other side decides several factors in the outcome. This is, of course, you have already heard so many complications which are known, and if you look at the studies of the main outcome measures following a distal gastrectomy, pylorus preserving gastrectomy or total gastrectomy, this is what the surgeon writes. I have done this particular procedure. What decides their outcome is factors like female sex, open approach of the surgery, and the nerve sacrifice, and independent factors, which I said one of the factors being nutrition, has a great impact in the overall outcome. Dumping syndrome, personally I feel it's not a very great thing, maybe because of the techniques, maybe because of the nutritional support, and he being advised how to take the nutrition, and even you have the nutritionist, not the dietitian, who decides the kind of small frequent meal, etc. The dumping syndrome is again we don't see so much, all dyspeptics are not, but one of the worries is when a patient who post-operatively comes with a phenomenon of dumping syndrome, we are always worried about recurrence. Not surprisingly, in 1/3 of the people we do pick up on an endoscopy which is easily accessible for everyone, we pick up the recurrence at the stump or the anastomotic state. Two areas which we were looking, instead of talking about antacids, we took two products which probably help in these post-op gastrectomy people are, one is the sucralfate, which has a biological action, and the probiotics, which seems to have some impact. We are actually doing a prospective study on the role of probiotics in post-gastric and post-colonic surgeries.